long time we are having consultants seminar. Now, my topic today is dysmorphic short stature. See, in dysmorphism, always you need to keep your mind open, and human mind is like a parachute. It only works when it is open. Why should an endocrinologist learn this morphology? So you start always with a bouncer. I always start with a bouncer. I was not a very good cricketer, but it's to bowl fast. This case, all of you know that this child came with, this is the child when he was normal, 6 months before the onset of the illness. And then within 6 months, this child started having this type of self-mutilation and obesity. So when I was asked to see this patient, Hridaya told me it's a rapid gain in obesity. And the clue was there, the rapid weight gain. On that day, I was little busy, so I didn't go further. And that the rapid, I kept my parachute open. This might be rapid onset obesity. So the moment you get the rapid onset obesity, then it goes into your Rohat-Net syndrome. Next day, we saw the X-ray again, and there was a shadow hair, which initially we didn't give enough importance, or maybe we were thinking of some pneumonia with obesity, because we started our investigations with MRI of the brain, and the MRI of the brain was normal. And then next day, we did an MRI of the whole of the sympathetic axis to see any neuroendocrine tumor there. You have seen all these tests before. I'm not going into details of that. So it became a Rohat-Net syndrome. It was operated, and subsequently the biopsy was proven. And there are a lot of endocrinological problems in this Rohat-Net syndrome. I'm not going into the details of that. My dysmorphology interest came from my boss, Dr. S.P. Ghosh, who was also the president of Indian Academy of Pediatrics, the first Bengali president of Indian Academy of Pediatrics. And we are proud that he's the only Indian who has a disease in his name in Oxford Medical Database. When I searched, there was another person, but he's not working in India anymore. He said there is a disease in his name. Now, and I was a co-author of that paper. কোথায় গেল রে? আমি বলেছিলাম ওদেরকে ব্যাটারিটা দিতে। ওদের কাউকে একটু ডাকতো, শোন না, ওদের কাউকে ডাকতো, এটা আমি বলেছিলাম যা। Subsequently, gene for this was diagnosed to be TBXS1 gene and chromosome 7. Chromosome 7, chromosome 11, chromosome 16, these are notorious for all these syndromes. After that, what my boss did, I did the same thing with my PGT. This child came to my outpatient clinic. I don't know who brought it, maybe Priyanka or someone brought it to my clinic. And I immediately thought of this is a progeria. And I have sent my PGT, Birendra Rai, to Chhapra to find out the whole family, to bring the whole family. And this is the whole family and was diagnosed as the largest family of progeria in the literature. And for this, I got a call from Amitabh Bachchan's office also, because Amitabh Bachchan was doing PA at that time, after that. So they wanted to help the family. And you see that there is no clavicle. But the beauty of this is that you will be able to feel the clavicle, but in X-ray will not be seeing the clavicle because it's a fibrous one. And myself and Priyankar Pal, along with the team from University of Switzerland, Basel, a lamine SE chain. I'm short, you are tall, who is best of all? So, I mean, many parents come to me that to height badiye din, mother is short, height to badiye din. So I tell them that it's not the short stature that's a problem. And I talk about Shochin. Now, will you believe that this man of 4 feet 9 inches, the world record of this painting by this man was 164 crores rupees in an auction, Christie's auction, 164. That's the highest that you can have. And that was a painting, this is a laundress by this man, Tolesa Lautrec. And do you know what is there in that stick? That used to have the alcohol. He was an alcoholic because he was from an affluent French family, but because of his height, he was not liked by the girls very much. So he used to go to prostitutes. And if you go to the net and you'll find lots of paintings he has done on the prostitutes. But whatever it is, the height is not at all important. And this is a child. I'm not talking about the disease that man had. This is a child which came to our outpatient department and with a crowding of the teeth. And this is a prominent mandible. And as you see, the terminal phalanges were hypoplastic. With that pictures, we did an X-ray. We did the X-ray of the skull. We did the X-ray of the mandible. And we did the clavicle. Now, the clavicle is osteolytic. There are very few conditions where you have these syndromes with osteolytic clavicles. It can be your progeria, I have told you. It can be cleidocranial dysostosis. And this patient also had. And you see the bones are very hyperdense. And as I said, that cleidocranial dysostosis and others, progeria. The pelvis was very characteristic. Look at the supra acetabular constrictions and look at this spool-shaped vertebra, very classic spool-shaped vertebra. You know spool, shuto jaraay na? So say shuto jaraay spool-shaped vertebra, and this is almost like an osteopetrosis. Now, I always say that our training in postgraduates undergraduates is not at all the ideal one. See, this is a 100 pediatric picture test needed for passing MRCP. And this is an Asian boy who had these pictures and they wanted the diagnosis. The diagnosis was pycnodysostosise. To them, it is not rare. You need to see the patient, diagnose, and then go deeper and deeper. It's no point learning about bone marrow transplantation, liver transplantations in MDs and others. First of all, you need to, with this knowledge, actually, I was able to diagnose this patient of pycnodysostosise. And look at the classic description given by Dr. Sukanta Bhattacharya of the patients. Now, again, this child, you have seen this child before, came to me with a blood gas report of short stature and blood gas report of 7.54. And no one undressed this child. The person who has done the blood gas didn't undress the child. It was brought to me by Shankar Babu, and I undressed the child. So initially what I thought that this child has a bowing of the legs. But the child was 3 years old. That's where the knowledge is important. At 3 years, there should not be bowing. Initially, I was thinking of saying that, oh, it is physiological. Then I undressed the child, did an X-ray, and the metaphyseal is ingrowing. See, it's almost like what you see in achondroplasia. Look at the vertebra, anterior tongue-shaped projection, and look at the metacarpals and phalanges. And look at how it was described by Dr. Sukanta Bhattacharya and Devashish spondylometaphyseal dysplasia of Kozlowski type. Next is that after the endocrinologist, why should the ophthalmologist learn the dysmorphology? See, this child went to LV Prasad for not seeing at night and for the blindness. They also came here. Now, when I saw the child, I again undressed the child and found that his thorax is very long thorax. So I did a lateral X-ray of the chest, and you see it's so short. It's an asphyxiating thoracic dystrophy or June syndrome, and the rest you will find almost like any other chondrodystrophy. And look at the X-ray of the hands of this patient and also the skull. Now, what is interesting is that visual loss as the presenting sign of June syndrome. So when a patient comes to you with visual loss, don't ignore, try to see if there is anything else which I need to diagnose the patient, which the ophthalmologist might have missed. And this is one of the 2 cases of my June syndrome. And there, what you can see, this one, the spinous projection and square-shaped ilia, that's very characteristic of June syndrome. Though terminologically, it's called asphyxiating thoracic dystrophy. If they can tide over the first couple of years, they do not have the respiratory distress after that. They die of your renal problems, thoracic cysts in the kidney and renal failure. A little bit about mucopolysaccharidosis, because you know there are 7, some says 8 types. Hurler, you know, they have the corneal clouding. Hunter, they will not have the corneal clouding because a hunter needs to see. San Filippo, you remember that there is N in it, so there will be only neurological features, no somatic features. That's for postgraduates. If there is N, it will have neurological features. Morchio, you know it's same. Marotex lami, they will not have any neurological features because there is no N in it. So they will not have neurological features like San Filippo. Sly is very rare, and many of them has got the therapy. Now this is We are talking about the Morquio syndrome the other day. This child came within this week only, that Morquio syndrome. The trunk is very short. They have lumbar lordosis and kyphosis, and the X-ray was showing the features of chondrodystrophy. It's a chromosome 16 defect. And in most of the cases nowadays, we are doing the genetic studies also. One of the features of this mucopolysaccharidosis group is that the ileum is fan-shaped. Whereas in achondroplasia, it is squared, but in lower lateral region, there is a center, and that is missing in achondroplasia, any mucopolysaccharidosis. And this is another one which came the other day, where there was corneal clouding, and you see this is another classic fan-shaped ileum that you see. And the spinous changes and the thoracic changes. Now, there are 5 groups of short stature. I'll be discussing only few of these short stature with dysmorphic features. It can be proportionate, disproportionate, syndromic, non-syndromic, and then syndromic with congenital heart disease, with skin abnormalities, and with limb defects. Let me show you some, and some of them are very short. Now, this is one dysmorphic short stature. I still repent. I repent because the first case that I diagnosed, I diagnosed the patient, but I didn't read up the disease immediately because it's not possible. And I didn't advise them not to go for the swimming. Now, this child, who was a student of our the challenge children, went to the village, went in a winter, went to this pond, and then had the myotonia of the muscles and was drawn. So, Schwartz-Jampel syndrome. This is a Schwartz-Jampel syndrome where you see the myotonia, the pursed lips, and myotonia of the sad fixed faces. And so to diagnose this patient, I've sent this face to Dipanjana, and Dipanjana have put it in the face and recognition. And she has then agreed, yes, sir, what you diagnosed is on the top. Then I have referred it picture to the Kaushik Banerjee and his Kaushik Mandal. He said it is nothing but a Schwartz-Jampel syndrome. Then I approached Hriday. He's a master man in computer, especially in finding out these books or whatever it is. So then Hriday has downloaded this software, and now you can diagnose this. And that also gave us our diagnosis, which I'll be coming later. Now, there is no doubt that this patient has got Turner syndrome. But what is important, when you have the lymphatic abnormalities, be very careful to look at the heart, because they will have cardiac abnormalities. Because of the lymphatic flow, they have the cardiac abnormalities, and they have 11 times more chance of coarctation, 11 times more chance of coarctation, both flow and non-flow related heart disease. So this is a Turner syndrome. I need not to go into the detail. And what is interesting, that we all know that females are 2X, and one is inherited from the father and one is inherited from the mother. And do the same function? Probably no, because when a Turner inherits from the X chromosome from the father, what are the qualities they have? And when a Turner inherits from the mother, what are the qualities they have? And that has been studied. If you inherit the Turner X chromosome from your father, It's better adjustment, superior verbal, and higher order executive function skill. I agree with all excepting the superior verbal, because you know, when the females fight, they fight so you'll not be able to know. So, but still, that's the study. That's a very interesting study. It should not have been allowed to publish also. But similar to Turner syndrome, there is another disease called Noonan syndrome. Now, what is the characteristic of Noonan syndrome? If you see pectus carinatum excavatum combination, the upper part is carinatum and the lower part is excavatum, and along with the short fourth and fifth metacarpals, you think of Noonan syndrome, which is a PTPN11 gene on chromosome 12. And Noonan syndrome patient, if you find a Noonan syndrome patient, before doing any procedure on these children, do a coagulation study very well, because the von Willebrand factor also is from the coagulation, and they have almost 54% of the cases may have a bleeding disorder. So that's the important. It's a male Noonan. This is another Noonan. The reason I'm showing you this picture, what you see here, this Noonan syndrome had a sternotomy scar. They have the pulmonary valve stenosis. No, it's not stenosis, dysplastic, and they cannot have usually a balloon angioplasty. They need an open operation for that. But nowadays it is slightly better. They can do even without an operation. And this is another Noonan. This is a Noonan, which is a very early part detected, and their features are usually much better in the early part of life. This is another Noonan, and it was not diagnosed as Noonan. The cardiologist has done everything. They have there was asymmetrical septal hypertrophy, distal dysplastic valve, but it was not diagnosed as Noonan. We have sent this. And now this is one patient when Pratiksha brought this child to me, and looking at these so many lentigens in the body, it was most probably thought of neurofibromatosis at some point. But remember, the neurofibromatosis will have a much bigger capillate spot. If you have so much of small capillate spots, then think of Leopard syndrome. And subsequently, we did the genetic study, and it was Leopard syndrome. This patient also had a septal hypertrophy. So Leopard and Noonan, they are more or less PTPN gene associated. So they may be a similar disease. And this is my first Leopard syndrome, where it is also associated with deafness. And you know the Leopard, though I don't like the term Leopard because you cannot give the name of an animal to a human. So it should not be done like that. And RAS MAMK pathway is very complicated, but most of these disease pathway defects are like Legius syndrome or cardiofasciocutaneous syndrome or NF1 or Costello syndrome. They are the ones which you have. Now this child came to me yesterday only, very, very characteristic faces, but the diagnosis was not there, but they did a genetic study. This is a Cornelia-de-Lange syndrome. This is another Cornelia-de-Lange syndrome. But if you have this lip abnormalities, it becomes very classic that it's a Cornelia-de-Lange syndrome. Their umbilicus is very characteristic, as if someone has operated on this umbilicus. So that's very characteristic. The Cornelia again, but looking at the thumb, you can diagnose, like one is diastrophic dysplasia, hitchhiker's thumb, and this is, which is a slightly broad thumb, which is a Rubinstein-Taibi syndrome, which is again a chromosome 16 defect. As I said, chromosome 7, 11, 16, these are notorious. And they have characteristic features, which I will have to go sometimes else. Russell-Silver syndrome. Now, you see these incidents before we did the genetic studies was 1 in 3,000 to 1 in 100,000. 50% of them will have hemihypertrophy, 50% will not have the hemihypertrophy. If you have a hemihypertrophy, it becomes very obvious. This is a clinodactyly they have. And this is a case which I think Hriday diagnosed that this is a Russell Silver. He did the genetic study and it was on the chromosome 11 instead of 7 that I was talking, which is a newer gene. And almost 50 to 60% of them will have this genetic defect of chromosome 11. But remember the Beckwith-Wedman syndrome is also a defect. I'm not going into the details how it causes Beckwith and how it causes Russell Silver syndrome, but it is. There is a criteria for diagnosis, clinical criteria. And as I said, the Russell Silver can be in chromosome 16 in 50 to 60 and 10% in chromosome 7. This child was not diagnosed for a long time till they came to our clinic, and because no one looked at the back of the ear. If you look at the back of the ear, you'll be able to find the tongue was bigger. Now, hypothyroidism is a cause where you have the bigger tongue, but not all. The Beckwith-Wedman syndrome will have a bigger tongue, and that's again a chromosome 17. And this is a Beckwith-Wedman syndrome in our NICU. But be very careful. I've seen in the beginning of your career, you become very syndrome-minded, and you diagnose that Apurba Ghosh has progeria because he doesn't have a hair. So it's a progeria, and he is deteriorating in his mental function. So it must be some aging problem and premature aging, which is not. I'm now just touching 70 years. This child was sent to me by Dr. Devashish Mukherjee. Initially, I thought, oh, it is a Russell Silver syndrome. The head is large, very thinly built, not growing well. But looking at the height, and somehow or other, sometimes it helps because we need to support our MRI also. Too much. So I did an MRI of the brain, and it is nothing but a hydrocephalus. So that was the causing the large head in a thinly built child, which is not Russell Silver syndrome. Seckles Bard-headed dwarfism is one. This is one patient which I diagnosed when I went to NRS Medical College in taking exam in 2000. Then why should an infectious disease specialist learn this morphology? And Ritopoto and Kea, two stalwarts of infectious disease. Why should you learn? You don't need to. Okay, fine. Now this child came to me with fever for a long time of 21, 22 days. What I found is that his eyes were much less light colored. And then there was no other features. So antibiotics is not going to work everywhere. So what I did, I told him that you admit this child in an air-conditioned room and I will see that the temperature, because to me, it was a hypothalamic disorder, and admitted in Neotia for 96 hours, there was no fever. I called one of these senior pediatrician and he said, "Aisa ho hi nahi sakta," because he didn't have the idea that the hypothalamus controls your temperature. So I could diagnose at that stage only hypothalamic disorder. What I also diagnosed that this child is having a very rapid growth. This child's mother complained that there was birth asphyxia at the time of birth because that the child needed a long-term tube feeding. Now, with that this is not a disorder, but I cannot tell you this is 20 years old, 20 years back, if not more. So they went to USA, and this is the stage when the diagnosis of Prader-Willi syndrome was made. That was the first time in India I've seen a Prader-Willi syndrome, and that was diagnosed. Then importance of doing the growth chart. This is another growth chart which is showing a very rapid growth brought from Agartala with a diagnosis of sepsis in a hypotonic stage. I also started treating the child as sepsis patient. Baby gradually improved, and I followed them up. And what I found that the baby is growing very fast. That's the stage. That's the importance of growth chart. And this is the child. And I did the fish study, and it was confirmed that it is a Prader-Willi syndrome. Lucky though, because 70% the fish will be able to tell you, but methylation is the one which will give you a 99% case of the diagnosis. After that, if you want to see that whether it's a paternal deletion or a maternal uniparental disomy or an imprinting defect, you will have to do some tests where I would refer the patient to genetic and Hridaya for further analysis. This child, you see, very happy, very light colored hair, and parents are of normal. So the reason I'm showing this is the Angelman syndrome, which is having a seizure disorder, and that's an Angelman syndrome. The next is, why should a cardiologist know about syndrome? I think I will stop here today. After that, we'll continue the next day. This child was seen in one of the premier center of cardiology, was having a coarctation of aorta, but they look at the eyes are too big. It's too big. Such a nice looking eye is not always good. And this is Kabuki syndrome. I talked to the lady. See, if you have seen a cardiological defect, try to find out that if there is anything. Look at the baby as a whole. And this is another Kabuki syndrome that we have. The last, I will end here, that this child was seen by in a premier institute, was operated, but was not cyanotic heart disease, conotruncal defect. You should always look for your 22q11 deletion. It has an important bearing because they might have some calcium problems initially, but that goes away. They might have immunodeficiency. They improve with time. And this is the child who had a conotruncal. This child was not diagnosed by me, but was diagnosed in USA. But look at the smile of this child, because he has a palatal problem. When he talks, there was a palatal problem. And that was when it was being diagnosed as 22q11 deletion. And this is the tubular nose of Dijor syndrome, very classic tubular nose of Dijor syndrome. And because it's going to YouTube, I have hidden one picture. The mother came to me after doing an operation in Reliance in Bombay, a cyanotic heart disease, a conotruncal defect. They did a CT scan, and CT scan showed there is no thymus. But still they didn't do the chromosome study, but that turned out to be a 22q11 deletion. And Williams syndrome is again very commonly missed. This is again a Williams syndrome. This is a Williams syndrome. And this is the Costello syndrome. I think I will end here today. It's almost 12:20 because they need to go for ward round and work also. But thank you. If you permit me, I can continue for the next week. But the next week sponsor, I will sponsor Shigala and Misty. Incidentally, আজকে আমার মার first বাৎসরিক day. So I thought I will, but Hridaya is so nice of him. He said, "Sir, আজকে আমি খাওয়াবো." Thank you, Hridaya. And we are improving because of Hridaya, Prabhash, Priyankar. Priyankar is beyond now. আমি দেখে এসেছিলাম